Here's our quick blueprint for today. We'll cover macroscopic classification, management principles, a key clinical pearl, a classic exam trap, and we'll finish up with a quick recall question.
Section 1. Macroscopic classification, also known as Type 0.
Okay, let's dive into this. We're going to look exactly at how we categorize the gross appearance of these lesions. But before we get into the specific types, we absolutely must establish our baseline. I need you to lock this definition into your brain right now. Early gastric cancer is defined strictly as cancer that is confined to the mucosa or the submucosa. That's it. That is the fundamental histological boundary line. And crucially, this is huge, it is irrespective of lymph node involvement. A lot of us instinctively think the word early means no lymph node spread, right? But in the context of gastric cancer, early refers exclusively to that depth of tissue invasion within the stomach wall itself. Now let's walk down the visual progression of the JJCA macroscopic classification, again known as Type 0. I want you to imagine you're looking right through an endoscope, checking out the stomach lining. We start high and literally work our way down. Step 1 is Type 0-I, which is your protruded, raised, or polypoid mass sticking out pretty prominently. Step 2 drops down a bit to Type 0-2I. This one is a superficial, just slightly elevated lesion. Step 3 levels out entirely. That's Type 0-2B. It's completely superficial and totally flat. Then moving down into the tissue, Step 4 is Type 0-2C, a superficial, depressed lesion. And finally, dropping to the lowest morphological point, Step 5 is Type 0-3, which is a deeply excavated ulcer-like lesion. So from a raised mass all the way down to an excavated crater, that's your morphological progression. Section 2. Management Principles. So figuring out the morphological shape of the lesion, that's really just the first part of the battle. Next, we actually have to know what to do with it clinically. When you're looking at the management of early gastric cancer, I want you to remember this absolutely critical principle. Macroscopic appearance alone does not determine your treatment plan. You can't just spot a Type 0-IC lesion and automatically know the exact surgery required. Instead, the clinical decision relies on a whole combination of factors. We're looking at the depth of invasion, the specific histology of those tumor cells, the overall size of the lesion, whether ulceration is present or absent, if there's any lymphovascular invasion, and, heavily tied to all of those, the calculated risk of lymph node metastases. You've kind of got to synthesize all these data points together to form your actual treatment strategy. Depending on those exact factors we just talked about, management essentially splits into two main pathways. For your very early, low-risk lesions, meaning they're highly superficial, small, and have favorable histology, the patient might actually be suitable for an endoscopic resection. Specifically, an endoscopic submucosal dissection, or ESD, is frequently used here. It's minimally invasive, and best of all, it spares the stomach. But you have to draw a hard line in the sand here. For lesions with a high risk of lymph node metastasis or deeper submucosal invasion, an endoscopic approach just isn't going to cut it. These patients require a formal gastrectomy along with an appropriate lymphadenectomy to clear out those at-risk regional lymph nodes. Ultimately, the depth of invasion and the node risk dictate which side of this dividing line your patient's going to fall on. Section 3. Our key clinical pearl. Now, what's really interesting about this slide is that it contains the absolute highest yield fact of this entire topic. Seriously, if you only remember one specific subtype from this whole explainer, make it this one. Type 0-2IC, the superficial depressed type, is the most common morphological type of early gastric cancer encountered in clinical practice. And because it's the most common, guess what? It is the single most frequently tested subtype on board exams. Write it down, highlight it, put a star next to it. 0-2IC equals superficial depressed, and it is the most common. To make sure you never forget this progression, I want you to take a mental screenshot of this table right now. This is your quick memory aid to permanently lock in those Roman numerals with their corresponding physical shapes. Start right at the top. I is raised. Then we hit the II series, which are all your superficial ones. IIA is elevated. IIB is flat. IIC, our most common star player, is depressed. And finally, 3 is the deepest, the excavated lesion. If you can just visualize this simple map in your mind's eye during a test, you're going to instantly decipher pretty much any morphological description they try to throw at you.
Section 4. The classic exam trap.
All right, I need you to pay very, very close attention here, because this is a cautionary tale where incredibly smart students lose easy points. Let's make sure you aren't one of them. Examiners love, and I mean love, to test your ability to separate out classification systems. You absolutely must not mix up the GGCA type 0 classification, which is strictly for early gastric cancer, with the Borman classification system. The Borman types I through V are reserved entirely for advanced gastric cancer. I know these sound super similar because they both use Roman numerals to describe morphology, but they apply to entirely different stages of disease. Keep them totally siloed in your brain. Type 0 is early, Borman is advanced.
So, the crucial point is, well, it brings us right back to that definition we discussed at the start. Early gastric cancer is defined by depth of invasion, not by the presence or absence of lymph node metastasis. A tumor is still classified as an early gastric cancer even if the regional lymph nodes are heavily involved, provided that the primary tumor itself hasn't grown past the submucosa. Exam questions are going to try to trick you. They'll describe a mucosal tumor with positive lymph nodes and then offer advanced gastric cancer as a tempting answer choice. Don't fall for it. The primary tumor's depth holds the key.
Section 5. Quick recall question. Okay, you've absorbed the structures, the management rules, and the pitfalls. Let's put that knowledge to the test. A gastric lesion is confined to the mucosa and submucosa, and it appears on endoscopy as a superficial depressed lesion. What is the precise macroscopic classification? I'll give you just a split second to lock in your answer.
And the answer is type 0-IC. If you got that right, huge congratulations. You have successfully mastered the most common and highly tested presentation of early gastric cancer. Just think about how incredible it is that simply by recognizing whether a lesion is slightly elevated, flat, or superficially depressed, like our type 0-IC right here, you're taking the very first step in a cascade of clinical decisions. Decisions that will ultimately determine whether a patient gets to go home the exact same day after an endoscopic resection, or if they're going to require a major gastrectomy. Understanding these subtle macroscopic differences doesn't just win you exam points, it quite literally dictates a patient's entire surgical outcome. But what happens when that tumor finally breaks through the submucosa and dives right into the muscularis propria? Well, that crosses the boundary into advanced gastric cancer, and that is a whole different ballgame for another time. Thanks so much for learning with me today, and I'll catch you in the next explainer.